Good morning, everyone. My name is Jennifer Zito, and I am the Connecticut Criminal Defense Lawyers Association representative on the Sentencing Commission. I also co-chair, as Judge Pavia told you, the Mental Health Subcommittee for the Commission. I am a practicing lawyer of 35 years, specializing in criminal defense, and I'm actually a graduate of this law school. And it is my privilege and honor to be here today to moderate this panel. And so we want to welcome you all, and we want to let you know a little bit about what the panel is going to be speaking about today, about mental health and incarceration. But the Commission, as Judge Pavia stated, is looking at this issue from a global perspective. We've realized all of us involved in the system, all of the stakeholders have recognized that mental health is at a crisis level in our state as it intersects with the criminal justice system. But the degree to which that crisis exists was, I think, even more profound than we knew, and the studies that the Commission has undertaken have really revealed the extent to which we are at a crisis in our state, and nationwide there is a crisis as well. So this panel, in looking at this issue from a global perspective, the Commission is guided by the sequential intercept model, which the pamphlets are found on your table, to inform a community-based response to the involvement of people with mental health and substance abuse issues with the criminal justice system. And as you can tell, if you open the pamphlet, there are intercepts at which we need to address our community response, numbered from 0 to 5. We are going to be concentrating in this panel on intercept number 3. So what that means is we are looking at a response to mental health issues and substance abuse issues intersecting with criminal justice from pre-incarceration, pre-arrest through reentry. And so every stage of the proceeding, we need to address this to have a global collaborated response. So the overarching goal of this intercept model is to promote community alternatives for people with mental illness by improving a cross-system collaboration to reduce the number of people involved in the criminal justice system. The Commission, as you know, is focused on evidence-based practices and best practices, and in this instance, to return people to the community with input from all of the stakeholders by identifying gaps in services, gaps in resources, assessing priorities, and ultimately making recommendations to the legislature to transform the system. The panel will focus on the treatment of the mentally ill while incarcerated and the impact of incarceration on not only the mentally ill, but also on DOC, the Department of Corrections, who is constitutionally mandated to provide behavioral medical services to inmates. We're also going to be looking at the impact of incarcerating the mentally ill on the DOC workers, staff, administrators, and the cost to DOC. I would like to introduce our panel members. First to my left is Senator Austin, who is the senator from the 19th District since 2012. She's served as the Senate's Deputy President Pro Tem since 2016. What you may not know is she's an Army vet, and she spent her career, over 20 years, working in the Department of Corrections as a corrections officer and then a lieutenant. And as Judge Pavia stated, she is the impetus for the Commission's study of this issue. We are very grateful for her, and I am honored to have her on this panel. Next to her left is Denise Paley, who is a mental health and justice reform advocate. She is the mother of a son who has serious mental health issues, who has intersected with the criminal justice system. She has firsthand experience in crisis response from law enforcement through her son's pretrial incarceration over the past 4 years, and she's going to speak to us about the experiences she's had. To her left is Marisol Garcia. She is a first-year law student at the Vermont School of Law and a fellow at the Yale Prison Education Initiative. She holds 2 degrees in public policy, and she graduated from Wesleyan and MCC's Center for Prison Education. What makes her particularly unique to serve on this panel is that she served a combined total of 22 years incarcerated with probation and parole, and she is going to give us her unique perspective on what goes on inside, and with obviously the insight of somebody who has several degrees in public policy and law. Dr. Cherniak is to her left. He's an occupational physician, and he's the principal investigator of the health improvement through employee control, understanding the health and well-being of corrections personnel. He is going to give us his perspective of the impact of incarcerating the mentally ill on DOC workers and personnel, and the behavioral challenges they face, and the challenges they face with their own well-being. We are definitely committed to having all of the stakeholders at the table, because we believe that this will best inform policy going forward. So without further ado, I am going to ask that Senator Austin begin.
Well, thank you very much for your kind words and for the introduction. And I consider this the most important issue that we have facing us right now, in particular in the criminal justice system, is work around mental health. And I started working on this well before I was a legislator. When I was a correctional officer and a correctional lieutenant, I would often find myself in the legislature testifying on laws relative to mental health and other things relative to unions and women's rights. But I was clearly seeing a change in the demographic and the number of people that were incarcerated with chronic mental illness when we closed our 2 psychiatric institutions in the state without providing the resources for supportive environments and wraparound services. So I did ask the Sentencing Commission to look at this because as a legislator, I kept asking for an addressing of the number of people that were chronically mentally ill that were incarcerated. And I needed to prove to people that there was actually people that were incarcerated that were chronically mentally ill. Many people would say they are just people who have committed crimes and should be held accountable. And I was never saying that people should not be held accountable. What I was saying is that we needed to look at the people that were being incarcerated without services that would provide them an ability to be safe in the community and for the community to be safe also. So I asked many years for a bill to discuss this, and finally I said, well, no one's going to listen to me on having a bill on this. I'm going to write to these people and ask them to do some research on the number of people that are chronically mentally ill, different than substance abuse, those people that would have ended up in our psychiatric institutions had they still been opened. And the numbers that came out were astounding from my perspective. Although I didn't find them astounding, I think the general public would say, really, we have 28% of male inmates that are chronically mentally ill in the prison system and 80% of female inmates that are chronically mentally ill. What are we doing? Why are we doing it? And what is the outcome? So when I first did this, I asked for a couple of different things for people to look at. I asked them to look at the people that were incarcerated that were chronically mentally ill, ascertain if the class of inmates is completing a longer portion of their sentence. And why would they be completing a longer portion of their sentence? Well, many halfway houses and group homes did not want someone that was chronically mentally ill. They're much more expensive person to handle. They require often medication, they require treatment, and so they would often stay in the prison system for a longer part of their sentence. They would not be able to access some of the transitions for a smooth transition back into the community. And then I said, determine if this class of inmates accesses or is able to access programs which allow them for that smooth transition. And to that end, we also asked the Department of Corrections to give us an idea of what they would need for staffing. And they did. They submitted a report to the Judiciary Committee that outlined the number of staff that they would need to handle the issues of the chronically mentally ill. And it's around a $30 million price tag. And so when I was talking to my colleagues, they said, well, we should just make the Department of Corrections accountable for not providing the services. And I said, well, we're the legislature. If we don't provide them with the resources that they need to provide the services, then it's really negligent on our part to hold them accountable for something that we're not giving them the assets that they need to provide people those resources. So I have been convinced. I worked in the Department of Corrections starting in 1989. I worked at 7 correctional facilities around the eastern part of the state. I also worked at a private correctional facility up in Rhode Island as a captain up there on a per diem basis that handled federal inmates. So I've worked with minimum, medium, and maximum inmates, male and female inmates. And a correctional lieutenant in the Department of Corrections is within the confines of the direct contact with the inmate population. You're not an office worker, you are part of the general scheme of working inside our prison systems. So I really, I'm so pleased that we're finally having this conversation, but I always want to differentiate between substance use disorder, which is a problem and needs to be addressed, but someone that has chronic mental illness does not get over that chronic mental illness unless we provide them the resources that they need, unless we provide those wraparound services for someone to be successful when they get out of the department. And they will get out of the department. But if we have never addressed the issues that they have that got them incarcerated in the first place, we will not, we will always have that person make the same mistakes that they did to get incarcerated. So those are the things that I think are really most important here. And I say this because I would point out a couple of other things. If someone that is incarcerated and you're working, and I see the commissioners here, and if you're working in the Department of Corrections and you have somebody who was a chronic schizophrenic, maybe non-compliant with their medication, and they're in a facility like a dorm facility, which may have 90 individuals in that particular dorm environment, and they are decompensating because of their lack of medication. They might not be in Garner because the numbers indicate that Garner is the facility that they're using for those with really the very, very serious mental health issues that are in the Department of Correction now. And that's only for male inmates. With female inmates who are 80%, we just use the whole facility as a mental health facility, essentially. If that person decompensates, you're walking into a unit with 89 other people that are trying to deal with the consequences of that one individual. And that's not fair for the individual, and it's not fair for the other people that are in that particular unit. And it's not fair for the staff because the staff often doesn't know that someone has a mental health issue. They're not privy to that knowledge. And that's also a problem because when you're the one that is working day-to-day with somebody, and it is work day-to-day with between the staff and the inmate population, you will find that most staff do not know if that person may enter into crisis. You just don't know about it. And I dealt with those situations a number of times during my tenure, my 21 years. Now, I've been retired for 13 years now, so some things have happened, but I think our numbers of those that are incarcerated that are chronically mentally ill with a chronic condition, which should be treated like the chronic medical conditions that someone may have, like diabetes, like cardiac issues. But often mental health, because it's unseen and because someone can't tell, they think that you should just automatically get over it. So I'm really, really hopeful that people will start recognizing the crisis that we have put the Department of Corrections in without providing them with the resources. And full disclosure, I'm the chair of appropriations, and we have never had the ability to put those resources in. $30 million into a budget is almost impossible to get done. I would clearly like to put those assets in, and I think we should, but I wanted you to understand that I understand the numbers part of this also. So I'm hopeful that with the number of people that are here today and the panel that we have here, we'll recognize the severity of the issue, and we'll also recognize the fact that we set people up who have never had the services that they need to be successful when we incarcerate them and then reintroduce them into the communities without resources and without wraparound services. So thank you very much.
Thank you, Senator Austin. So as many of you know, there were state mental health institutions for a long period of time, and they were closed. And when they were closed, the legislature was supposed to fill the gap with funding for community-based resources, and that never happened. So what has occurred, unfortunately, is that DOC is now housing the mentally ill because they're not getting services, which creates their involvement in criminal behavior at times, and then they're housed at DOC, and as Senator Austin has stated, they're not getting appropriate services because DOC's core mission is not to treat the mentally ill. So they lack the resources, the funding, the training to adequately care for this population, and as Senator Austin has stated, there's a major problem with recidivism because people are then released into the community without having benefited from treatment, and they wind up back in DOC. So our next speaker is going to tell us about her personal experience as a family member of a son who had a psychotic break, ended up getting arrested, and has been held pre-trial. Denise Paley is here, and I'll introduce you.
Thank you so much. Thank you. And thank you to the Connecticut Sentencing Commission for inviting me today. So my name is Denise Paley, and I'm the co-president now of NAMI Shoreline, and I'm on the advisory board for DEMIS. But today I'm here as a mother whose son was arrested 4 years ago. So back then, he was just a senior in high school. And to give you a little background on my son, so my son Ellis, he's known as being bright, funny, he's well-liked. His natural disposition is extremely easygoing. Just to give you a little context, for senior superlative, he was actually voted most likely to sleep through an earthquake. He was. He was a strong student. He thrived in high school. He received a presidential scholarship to attend the college of his choice. And then one day, he went missing. He was experiencing a psychotic break. And initially, we had no idea. So this brings me to the first intersection between mental illness and incarceration. Because when Ellis went missing, me, his father, and his friends pleaded with our local police department overnight into the next day to help us find him and bring him home. After midnight, he was located by police, sleeping at a rest stop more than 1.5 hours from home. So prior to this, he'd never driven beyond a 20-mile radius. So between this and a few other indicators, we knew that something was terribly wrong. So we knew that he could not be in his right state of mind, and we clearly told the police officer so. A police officer told me that Ellis was not having a psychotic break. Well, he was. He was hallucinating, delusional, and had lost all sense of reality. And this unaddressed spiraling is what led to his arrest. It's my belief that if the officers we encountered had crisis intervention team training, that Ellis would never have been arrested, that he would not have lived his worst moment ever while just a senior in high school, that his future would not have been taken from him because that moment would not have led to his imprisonment. Instead, he was incarcerated at the onset of a very serious illness, one that requires proper treatment and a qualified team in place for support. Instead, he's been waiting in pretrial for 4 years in prison. Recovery from serious mental illness requires carefully prescribed medication, cognitive behavioral therapy to work through the experience, and family support. Family and social relationships, they are hugely important for recovery, as is early intervention, which is only possible with an available qualified team. Instead, Ellis is warehoused in a cell about the size of a primary bathroom. He's been terrorized by thoughts in his head. I remember one time he called and he said that the walls were bleeding. He was sent to the prison infirmary, which, for your information, is just another cell that involves a strip search where he was confined in complete isolation with absolutely nothing to distract his mind. Not a book, nothing. All stimulus is taken away. This is part of the reason that incarcerated people with mental illness, they don't ask for help, because the treatment can be more punishing than the illness itself. Then there's the overwhelming loneliness. So everyone here has lived through COVID, so I know you all know what it feels like to be lonely. Imagine the impact of loneliness on his mental distress. Ellis recently turned 22. We haven't hugged or touched our son in years. And it's taken years, so years of anguish. Mental illness can be excruciating for the person who's suffering. Ellis initially received no medication, then poor medication. With a lot of advocacy on our part and an engaged mental health counselor, Ellis was finally given medication that can treat his psychosis. He improved, and we were grateful for it, but he was given medications that are not to be used together in doses that should not be used, period. And he was essentially poisoned and had severe side effects. Ellis finally did access a more knowledgeable prescriber, and he's now receiving a good regimen of medications. And we've supported him during our calls and visits. We've applied therapeutic techniques that we've learned on the outside. We've supplied him with books and resources so he can aid his own recovery. Today, he tries to navigate the stress of prison on his mental health, and thankfully, he no longer suffers from psychosis. But he's still in prison. For what? Rehabilitation? What exactly is the Department of Corrections going to correct? DOC is a harmful environment. It can be brutal. Prior to his arrest, Ellis was never even in a fist fight. But since being incarcerated, he's had an altercation where he was not just injured physically, but he spent several more days in the infirmary due to the impact on his mental health. Mostly, he just sits in his cell all day. There's limited access to fresh air or exercise in prison. These are both critical for anyone's mental health. He's been trying to get into a college course, and he has been consistently denied for years. I asked Ellis what he's looking forward to most when he's free and what he wants others to know about living in incarceration. He shared he's looking forward to reconnecting with his family and his friends. His brother was just a freshman in high school when this ordeal began. Today, he's a freshman in college. Ellis had never even shaved when this began. He now has a beard. His grandfather died while he's been incarcerated, so he wants to see his grandmother. He wants to go to school. And as far as what he thinks you should know about living in incarceration, he's aware that being a corrections officer is a very stressful job. And he knows that they are simply not resourced to navigate everything that they encounter. But he describes it as a culture of extreme neglect. It's been 4 years, and Ellis has still not been sentenced. About every other month, he has a hearing. So figure over 4 years, that's about 24 hearings, 24 continuances of his case. I imagine the cost to the state for transportation alone is pretty significant. Then there's the cost to him. Each time he goes to court, he's strip searched and shackled. He's been shackled to others in a van, chain gang style. He sits in what's called a bullpen in the courthouse all day long, and for nothing. On the inside, this is referred to as bullpen therapy, and it is not rehabilitating. People ask me all the time, how is he still in prison? How is he still not sentenced? How does our state allow this treatment of people who, outside of their illness, would have never committed a crime? People are astounded by how our state operates, the money that's wasted, the lives that are wasted. My child, he's now a data point in reports that are presented at forums like this one. We need to stop looking at data. We need to start taking action. If it were not for the fact that I'm living this, honestly, it would otherwise be unthinkable. But our country is in a mental health crisis. There is no one in this room, there is no one, period, that's immune to this. So one last thing. When you go home later, make sure you hug and kiss your own kids. Your tomorrow is not promised, and it could be your last chance for a long, long time. Thank you.
Denise, thank you for that very emotional story. It's exactly what we need to hear. The insight of the firsthand experience is priceless. And we thank you for your vulnerability, and we thank you for sharing. And we wish you and your family the best, and we hope that we can inspire change that will affect you. Thank you. Next, we're going to hear from Marisol Garcia, and she is going to tell us of her personal experiences while incarcerated, as well as her involvement in research and policy efforts for change. And she serves on the DOC Advisory Board as well. And so, Marisol.
Good morning. So first I have to say it makes me very angry to listen to your story. It makes me angry as someone who has been in the carceral system, someone who advocates in the carceral system, because, you know, as the senator said, you know, $30 million is a lot of money, but we pay for that post-release in so many ways. So I was a hospice volunteer while I was incarcerated. I worked with the juvenile offenders in the Restoring Promise unit at York Correctional. I was a mentor in the facility for Sisters Standing Strong. So I have seen all aspects of mental health in the facility, from our juveniles to our older population and to those who, general population. The data that we have doesn't even begin to really cover the reality of what's going on in the prison, post-release, reentry. It doesn't even begin to cover it. So we talk about mental health, people coming in, The prisons are nothing but a catch-all. We no longer have the hospitals to do that anymore. However, you have those who already are coming in with a mental illness. Incarceration impacts and exacerbates the situation even worse. Now then turn that around and imagine those who may not have had a mental health or a social anxiety problem. Incarceration creates that. And why I can say that for a fact is I am 46. I have the worst post-carceral PTSD, and that is a thing that exists. Social anxiety, heightened very badly. Being in this room is very difficult for me. We talk about all the stakeholders. I'm the only, if not one of the few formerly incarcerated people here. All the stakeholders are not in this room. It is very difficult to have a conversation when it's not fully represented. So just be mindful of that. Second, I don't think people recognize that the mental health impacts are not just in the facilities, they follow you home. One of the reasons I got involved with the SAFE Center for Health and Justice, why I serve on the Correctional Advisory Committee. I have a lot of friends who have done 25, 30 years in prison, who are now coming home and who, like people who suffer from mental health issues, are ashamed to ask for help, are afraid because they don't trust anybody that's related to DOC mental health or anybody in relation to that to help them. Those problems affect you while you're in there. You talk about medication. So medication side effects, people are medicated while they're in prison because of the issues that arise from the crime, their incarceration, and they bring that home with them. And they have to live with that, and they're ashamed of asking for help. So those are the very things when we talk about mental health. We're not just talking about people with mental health issues coming into the facility. There are those issues that are created while they're there, and then they have to live with them post-release that affect juvenile offenders, former juvenile offenders who are now what they call juvenile lifers who are coming home now, and those who have who unfortunately are aging in the facilities, who may stay there and suffer from dementia or other things. These are all things. The data information that we have, unfortunately, as it is with any bureaucratic issue, it's not fully seen. And sometimes, again, there's certain things that are just not available. So without that, we don't truly see the breadth of the problem, but it is very big, very, very big. So the senator spoke about the committee I'm on. We're currently in the process of working on getting the ombudsman, and that's almost, it's beyond time because the mental health is a very large aspect that impacts the incarcerated population and the formerly incarcerated population as well. Oh, you okay. I apologize. She spoke of education. I think this is education that needs to be for the correctional staff, as well as those who are professionals, because I think that lack of awareness and lack of information makes it rather difficult for everyone. I was a graduate of the Center for Prison for Education with Wesleyan and Middlesex. That was one of the very things that got me through my incarceration. I heard you say that your son had not even been able to get into college classes. That affects a lot of people in prison. That sometimes is the only sense of normal that you have. That interaction, that's important. Those are those very things that prison takes away from you. You know, I go back to exactly what you were talking about, Senator Alstein, about the $30 million. We end up paying for that longer in more ways after incarceration. So sometimes we've got to decide, are we going to do it while they're incarcerated, or are we going to keep paying for it long after?
Thank you, Marisol. Next, we're going to hear from Dr. Cherniak. Whose work, research, and investigation into the well-being and mental health of the DOC staff and personnel is critical, and there's not a great deal of professional expertise in this area, so we are very lucky to have Dr. Cherniak here in Connecticut and addressing us today.
Thank you. I just want to say, if you give me an extra minute before you give me the hook, a second to acknowledge Kathy Austin, Senator Austin, because at two critical times, we would have no programs such as high-tech health improvement through employee control without her contributions. What she didn't say, because of insufficient vanity, was that she was the founding president of the Corrections Supervisors Union in Connecticut. And I'll only say, from my initial impressions, that when you're a female head of a union in corrections, when you don't get promoted to captain in a lengthy career, but stay as a lieutenant, and when you get assigned to 6 different sites, if I may speak for you, you need a thick skin, and you need to be very resilient. And so I'm going to talk a little bit about resilience and what that all means. So health improvement through employee control was the first nationally funded program from National Institute for Occupational Safety and Health called Total Worker Health. And when we started this 17 years ago, we had 2 basic themes. One of them was that what we call a design team, a participatory team of frontline workers, appropriately trained and appropriately prepared, could actually make major changes in their workplace. And the second part of this was that you can't just do health promotion and health. 10-15% of people take part, unless you're fundamentally changing the organization of the structure of the workplace. Now, we got involved in corrections, and my background was in musculoskeletal disease. I knew a lot about corrections. Not about corrections, I knew about construction. I knew about factory work. I knew about Chernobyl, where I'd done work. I didn't know very much about corrections. And the only reason we got involved is that members of her union came along and said, why don't you take on a real challenge? Why not? This is an impossible group to work with. We've tried stuff, and nothing seems to work, and I should say the organization has tried stuff. Why don't you really take it on? And our thought was, we don't know anything about corrections. We better take some time thinking about this. So as insurance, we took 2 different organizations on. One was the large aerospace employer in the state, you know the name. And the second was Connecticut Corrections. And if you'd asked me 18 years ago, I would have said, we'll do great in aerospace, and we'll give our shot at corrections. And we won't get that far. It's too tough. We don't understand it well enough. Too alien. So I wanted to just mention a couple of things. First of all, one of the things which got communicated to us, certainly from Senator Austin and from a number of members of her union, was that there was real recognition that the corrections environment was destructive of the lives of inmates, and it was destructive of the lives of staff. And the outcomes were bad. There was a lot of damage done. And also that mental health was a continuum from community to facility, back to community. And driving a lot of it was the fact that we have a very punitive society. And I'm not going to talk about that now. That's for another topic, but there it is. So what did we find at baseline? Because we started a baseline study. We found out some things that really shocked corrections and the staff themselves. One was that a corrections officer lives 12 and a half years less than other state of Connecticut workers. That physiologically, from our testing, they looked, a 35-year-old corrections officer looked like a 55-year-old factory worker in Connecticut. And that most of these changes were occurring in the first 5 years of work. What else did we find out? Very high divorce rates, clinical depression in almost a third of the population, a lot of substance misuse, and very hard to measure because standard surveys were not getting at it. And many things people did not want to talk about. I mean, mental health is not something that staff wants to talk about. They're concerned about privacy. They're also concerned about appearing weak. And there's also was an ethic of, suck it up and take it out on your family. The second part was a consequence, not necessarily a plan. So beginning in this area, let me tell you about how some of these design teams have worked, because right now we've got a presence with very modest investment, and a lot of it thanks to Senator Austin, with increasing almost every facility in the state, including educators and healthcare workers signing on and wanting to set up their own design teams. So let me give you two examples of what people do so you get a little better sense. First of all, these teams have to spend a lot of time preparing themselves of how to make interventions, how to influence the institution they're in, how to influence the system, how to work with the larger workforce, which in many respects doesn't share the views that change is possible or that much can be accomplished. But let me give, again, two examples. One was that one of our early programs was on indoor air quality. So there's a wide belief in corrections personnel that there were many diseases passed between inmates to officers and that they were getting sick because of these infections, because they had many respiratory symptoms. Turned out not to be true. What was true is the ventilation systems didn't work well. A lot of them were old. There was poor HVAC and maintenance. And the design team got itself prepared. And when they met with the state's DAS and with engineering, I think there was a kind of smirk in the room. Who do these guys think they're telling us about how to do our jobs? Well, they did know quite a bit about it. And they kind of came back again and again, found that the system problem really was a poor ventilation system. Inmates were often plugging it because the convection systems were poor and it seemed to be very cold, not because of temperature, because of convection. So people were reacting. And what was the solution? Well, they worked with us to design a survey, so they did pre and post, which really represented how to get to people. They also had assistance from the health department, from the Tools for Schools program, which isn't actually staffed now. That's something that could come out of this meeting. And they trained inmates and officers in HVAC, so that inmates had a basic training that they could eventually go out with and perhaps do something with, and conditions got better. Well, corrections officers and supervisors can be pretty stubborn and put in the right environment. They just kept coming back, and eventually the whole system got replaced. It was a capital investment which people said could never happen, would never happen. There were never funds to do it, and it just wouldn't be. Well, it was. So I want to just say a couple of things, because I am going to talk a bit about a positive story, and then I want to talk about how this deals with the issues you're here today to mostly deal with, which is primarily with inmates. As some of you, well, let me start with the conclusions. The last two Surgeon Generals, including the current one, who's a very strong and well-known public health advocate, have cited the high-tech program in Connecticut for being nationally leading. How many times have you heard of corrections being nationally leading, or Connecticut being nationally leading, and anything dealing with corrections or healthcare? Well, it is, and it's being acknowledged by National Institute of Justice, National Institute of Corrections. Practices are being copied. We've tried to involve systems around the country around common platforms, both on research and on practice. The other thing that really impressed our design teams was they were cited by the Swedes, the design teams, as doing internationally leading work. The Swedes never comment positively on American corrections or American work conditions. I mean, Swedes are the gold standard. They're the maximum. They're the smooth sailors in all of this. I say that not out of vanity, but because our guys and women took enormous pride in that. And it's that pride of continuous improvement, and also the fact we've been there for a while, and people who started out as officers doing high-tech work and design teams have now gone up into management positions, and they bring that with them. And the fact that there's this notion now of continuous improvement, when you do it piece by piece, well-structured, well-thought-out, well-trained, you can accomplish a great deal. And one thing I have to say that's impressed me all along is that I began with the idea you do successful interventions and you measure the outcomes of interventions, and that's kind of it. But the process ends up being as important as the intervention. How people work, how they work together, how they measure, what they learn how to measure, how they cooperate. These are really important things. And sometimes the intervention is not as important as what happens culturally. And I think we've accomplished a lot culturally. One of the former presidents of the Supervisors Union said, we've done a lot with you in 10 years, and if we have 20 more, we can really get something done. So what about working with inmates? Ms. Garcia talked about the Yale program, and I know Emily Wong and Lisa Puglisi have worked in this area in particular. They've looked at the incarcerated population as part of a community mental health population quite correctly. They also know that, that mental health issues and violence in the incarcerated population has its impact on the staff. And we know that too from a different aspect, because in our studies what we've seen is that when relations with the staff and the, I should say, the supervisors and the inmates are relatively good, or depending on how good they are, physical level of pain in the workforce goes way down, and depression goes way down. And we've got pretty hard evidence for that. The other thing, we did a small study recently, another area we can work on. We looked at what's happening. We're not supposed to do this. You know, we're supposed to work with staff and not with inmates. But we want to see, one of our people wanted to see what happens when inmates get released. A lot of people on the inside of the facilities looking at the transition point. But then you've got a voluntary community of halfway houses and so forth, which is very diverse, very dedicated people, very idealistic, very hardworking, but there's a breakdown. Even the basic medical forms and medical information that gets transmitted, despite having people in transition, doesn't work well. Is it a correctable issue? It's very much a correctable issue. But it just hasn't had that type of concentrated attention. It wouldn't be that difficult to do, but that's something that we've seen. The other thing I just wanted to say in terms of our own work is that that at least in Connecticut, and I think in most states, there's a pretty firm line that the line officers, line personnel, want to keep between themselves and the inmates. There's a lot of reasons for it. I mean, the common one that gets cited is that everyone is concerned about inmates, no one talks about us. You know, our problems are bad, we've got all these health and other issues, and no one cares. You know, we're just kind of a despised population. And so that's a real firm barrier. I remember when we first started, one of our members from Starr's decided that he'd like to set up a design team of inmates and officers, and he almost got thrown out of the room. So we've held off on that one for a while. I think it'll get there. Ms. Garcia commented the other week, we had a brief preparatory session, and one of the supervisors' union, its design team, has taken on some of the issues of internal violence as the primary topic for the year, as long as civility. And one of the unions wants to take it on. And they all pointed out, you know, this is about 30+ hours of training that people would need. And she said, well, 30 hours of training is 30 hours of lockdown. So you punish the inmate population. So if you're going to do it, you have to figure out a different way to do it. You have to use posting other forms. I'm not the internal expert on this. I mean, I'm an observer, but I can see how these things have been solved. And finally, I want to just say, I think this will happen. We can't rush things until people are ready. I could give you a program of how mental health work would transpire from staff to inmate and back, and how that could be set up. We're not there yet, but with the right cooperation and the right activity, I think we can get there in Connecticut. And let me just mention one funny thing, how things sort of work. We're trying to, right now we have an application with a group in South Carolina to jointly talk about some interchange between the two systems. Now, at most levels, Connecticut lives in a different civilization than South Carolina. Pay is about twice as high. Benefits, which are not much in South Carolina, are pretty good. As a result, the big turnover question, which affects corrections throughout the country, is not a big issue in Connecticut. You don't have that much turnover because people are reasonably paid. If we look at staff ratios, they're much higher in Connecticut. If we look at the non-custody staff ratio to inmate, it's higher in Connecticut. All those things are true, which would make it a better system. But there's one thing they do that we don't do, and I'm just going to suggest that as my last comment. You know, partly through setting up our national systems and our national communications, we're getting NIC to look at best practices. One thing they do is they have committees of inmates that meet and advise on work conditions and on mental health, and they're quite effective. And what they found is with all what seems like a backward system, gang rule, and so forth in the system, they've found a lot of very constructive work being done by the inmate committees, and with a lot of very good ideas. And, they have the same fiscal crises and everything. We don't do it here, but I think we can certainly learn how to do it here. If we get funded, not that any of you have influence on the National Institute of Justice, part of the plan is for them to come and introduce some of those methods in Connecticut. But just to say that there are populations out there that can be of great assistance, both the working population and also the inmate population. And despite the usual pessimism and dourness and fatalism that accompanies corrections, we have done some things extremely well. And that's all I will say.
Thank you, Dr. Cherniak. You just mentioned that they have inmate subcommittees that have great ideas. Do you find that as well, I'm assuming, with the DOC workers and the staff, that they have good ideas for change?
Boy, I didn't give a very good talk. I really goofed. That's what the whole design team concept is about. The group gets together. It goes through a 7-step process. It's not a 7-step program. It's a 7-step process, which we call ideas. I can get people the information. A lot of this is in print, much is in public domain, quite a few articles, where they start with identifying problems and barriers and what they want to accomplish, and narrow that down into specific actions and specific packages of action. And then we thought initially that once people had done that, they would go away and DOC would take it over. Nobody who spent that much time on a plan for change ever wants to leave. They're going to stay with it. And that's the other thing that we really found. So yes, the 2 examples I gave you, well, one example was the indoor air quality. The other example, which is probably not a bad one, is that there's a big movement right now, totally staff-driven, on peer mental health. And they want to train people in every facility, train fellow and sister officers to be able to handle such things as mental health triage, work-life balance, work and family life, finances and starting your career and not getting yourself in a big economic hole, for example. They want to train people in every facility to be the number, to be able to advise their coworkers, and they're moving ahead with that. The other thing is every design team right now is putting almost all of its emphasis on mental health of the staff. And they brought in outside people. Wheeler Clinic came in. They brought in experts to teach their own program. They have negotiated in contract a preventive health day, or preventive health days as it turns out, with the pre and the post questionnaires and study and outcomes. And those have all worked. And one of the areas that almost every facility we've worked with is putting in is what they call recovery rooms. The idea being that when things seem out of control, when the officer feels that something is getting out of control, that they're out of control, that the tension is building, and they're moving towards physical confrontation, verbal or physical confrontation, they can time out. Or after something critical has happened, like a violent episode, they can go to this recovery room and spend the necessary time to get back on their feet and not carry it on. And we've sent that a number of times, and people talk about it in these groups, where there are people who are officers who have direct experience in their neighborhoods, and they've got a lot of insight into where many of the inmates are coming from, and can often intervene early before things get wild, including things like self-harm, mutilation, and so forth. There are other people who are not necessarily beginning this with overt racism, but they don't see it, they don't understand it, and then it just escalates and escalates and escalates. So the staff has a lot of insight into that. And that's something that you're not necessarily going to get anywhere else. So yes, we see a lot of positive outcomes.
Thank you. That's what I was hoping for. So your work is critical, and Connecticut is often on the forefront of issues involving the criminal justice system, but we do need to do more, as clearly you've heard this morning from this panel. In my experience, and before, I'm just going to speak briefly, we're going to take questions for about 15 minutes in a couple minutes, I'll let you know. But in my experience, getting the money is going to be a very difficult task to get DOC the resources it needs to adequately manage this population. But the things we really need to be looking at, in addition to getting more resources, is we need to look at how to divert the prosecution of the mentally ill, and we need to work on reentry programs and community resources so that people aren't on a revolving door coming back in and out of the system. In my practice, in dealing with private, I'm not a public defender, I'm a private criminal defense lawyer, most of my clients suffer from serious mental illness. I tend to represent a younger population, from about 15 to 30 is the focus of my practice. And I encounter significant mental health problems with this population on a daily basis. While there are diversion programs in Connecticut, which are intended to provide services for the mentally ill and divert the prosecution so they can get help and assistance, and for those who are incarcerated to put them in jail diversion, put them in a bed. The problem with the programs is they are insufficiently funded, and there aren't enough beds, and our early screening process is in a pilot program phase, needs to be expanded. We need to do a lot more with the diversion programs that we have. Connecticut has good ideas, but unfortunately we haven't given the resources to these programs to make them effective. So I would just say that there needs to be a great deal of focus on diverting prosecution so people do not end up in DOC, take some of the burden off of DOC, and then help us with reentry so that people aren't coming back into DOC. So I hope that that will provoke some discussions and more research and more ideas relative to this critical problem that has reached a crisis level here in Connecticut and nationwide. And we now welcome any questions you have. Ava will be coming around.
I will be
with the
coming
mic.
around. And just starting us off, a question for the entire panel. How do you view the intersection between your fields and the experiences of incarcerated people? In other words, with how clinical policy and research can be, how do you feel it can better incorporate the experiences of those who have been incarcerated and their loved ones?
Senator Austin?
So today, it's because my work is revolving around policy and providing resources for people that end up being incarcerated and their families. And when I was, a long time ago, working in the Department of Correction, there's always work between the inmate population and the families when you do simple things that, in particular with the families, when an inmate, I worked with one of the inmates when I was working out of Brooklyn Correctional Institution, who's had a family member die, and I was able to get him permission to go to the funeral and provide the staff to bring that person there and bring them back. And when he came back, he said, thank you for providing me that opportunity. It made the world of difference to me because I didn't think I'd be able to see them. And visits is always, in the Department of Correction, is always that intersection between the inmate and their family. And I've worked at places where you never got to touch the person that you were visiting with, but I've also worked at places where there was contact visits. And I had this young family that came up, and the mom brought something in for the inmate. You're not allowed to do that. And they got caught doing that. And so there was a bit of discussion with the staff and the person. But there was a young 7-year-old that was involved in this situation, and I was able to call them over to the supervisor's area and had the inmate come over, explain to him what was going on, explain to the mom what was going on, but more importantly, it was a contact visit area anyways, allowed him to talk to his son before he left. And that gave him an ability to humanize that situation, and without creating a point where all that young boy was going to remember was that his dad was not allowed to see him, and that there was controversy about it, for doing what he perceived at 7 to be a normal interaction between his mom and dad. She actually brought a ring in for him. Can't happen. Nonetheless, you don't want to have that little boy think that everybody that wears a uniform is bad. And that was what was going to happen if I felt if I didn't take care of that particular situation.
So because you brought up contact visits, I just want to say as a general belief, the fact that we deny people contact visits in this state, I think, is inhumane. So I don't know why we have the practice of non-contact visits, period. But moving on, I think something that is pretty accessible that we could do relatively quickly, and it would serve both corrections officers and people who are living in incarceration, is have corrections officers receive crisis intervention team training, and they will be better able to recognize when somebody is having a mental health episode, and they will also have better tools to respond instead of react, which reacting is often what happens. So we have the Connecticut Alliance to Benefit Law Enforcement here in Connecticut. They are supported by DEMAS, and they could do the training for corrections officers.
So I actually had this conversation about what we could possibly do to make this better for the community. We don't have enough voices of the incarcerated or formerly incarcerated at the table. I actually had this conversation with Commissioner Quiros at a recent event we were at about possibly having an advisory capacity of an incarcerated person, formerly incarcerated person, work for the Department of Corrections in a part-time or full-time capacity that can advise. Because without the voices of the people who are impacted, we're never going to change anything. And when you talk about touch, as we know in corrections, that's a no-no, whether it's in visits at the facility. But you do realize that the inability to touch and have human interaction stays with you long after you finish your time. It makes it rather difficult to reintegrate back into society when you don't feel comfortable with other people, let alone other people touching you. So that mental health aspect, that's a thing.
If I could just talk about that touch aspect of things. So I retired in 2010. It took me 2 years before I was ever comfortable enough to not have my back to a wall when I sat any place. I today don't like people to enter my personal space. I don't like it. It makes me uncomfortable. And I've had people come up to me, because we are in a very touchy-feely society, and I'm not somebody that, I don't know whether I would have been touchy-feely even before this, but I tell people all the time, I had somebody that felt it was always necessary to come up and hug me. And I said to him, will you please stop doing that? I don't like it. And finally one day, after this person stepped over the line for probably the 20th or 30th time that I had seen them, I said, if you touch me one more time, I'm going to take you down to the ground. Stop touching me. I don't like it. And so we were out someplace, and this person was another legislator, and he said, well, you let other people touch you. I said, I get to choose. Please stop forcing me into a situation that is making me so vastly uncomfortable that I don't like to be around you. And I don't want to have you touch me. So that's not just a situation that happens with the inmate population. It's very much part of the officer population too. We are trained to be that way. We are trained to always have that personal distance all the time. And when you do that for 20 years of your life, you don't want to move on from that. And I just want to say one of the things that Dr. Cherniak didn't say, he said that we live 12 years less than other state employees. That's true. It's also true nationally. What he didn't say was, and I've seen it happen, we have a lot of correctional staff. We always go through spates. We haven't been in a spate in a long time where people kill themselves. Post-traumatic stress is not something that happens to just the inmate population, but I had friends who could no longer live with the way they were, and they killed themselves. And it wasn't just one. It was more than one. It was more than two. It was more than 10. And so these are things that I think that you have to start thinking about when you're talking about mental health and the system of the Department of Correction. That it's a system that needs to be looked at, and oftentimes people think that the TV image of a correctional officer is how they are. And I'm not saying that there's not one or two in the whole world that is not like that, but that is not true over the preponderance of the people that work in the Department of Correction. And I just wanted to clearly point that out because we always hear that the Department of Correction has its problems, and it does. But I would remind people that there are people that actually work in the Department of Correction system, that we need to remember that they are human beings also.
So can I just add something to that? Because she said the 12 years for the officers. For every year an incarcerated person serves, it's 2 years off their life. But let's also remember that whole concept of touch. I can only imagine it goes for the correctional members' families, but imagine the children of the incarcerated population. Touch is a problem. So imagine if you are going home and your little one asks you for a hug, and how hard is that for an incarcerated person to give? So you now have an intergenerational problem where a child of a formerly incarcerated person or incarcerated person doesn't know what touch is. So now you have it systemic. That's just something to think about, because again, that also probably impacts the correctional staff as well. You carry that stress home, it becomes a problem twofold.
We have time for another question or two.
Help me, I can't.
As long as it's quick, we have just a few minutes.
Hi, good morning still, right? My name is Cindy. Denise, I didn't know you were going to be on. I thought I recognized you, and I want to thank you because I felt you spoke for me and a lot of other mothers. So before I get to what I wanted to say, our correction system actually has regressed. Gail Burns-Smith, who's a former victim advocate, was taking restorative justice into the prisons decades ago, and that was eliminated. We used to be able to give Christmas presents to our loved ones, so you could tell an old-timer, a person incarcerated, because he still has a bathrobe that the new people coming in don't have. So there's been many, and hiring. Commissioner Quiros would say hiring's been a problem. So while I'm not going to create or treat the entire corrections group as one group, I know they're made up of individuals. There's certainly been enough of them in the news these days getting arrested for a lot of bad things. And so as a loved one, we get concerned by who is actually managing our people inside, right? It's a vulnerable group. The other thing I wanted to say very quickly is that because I am a mother of a justice involved, I'm an executive director of a statewide nonprofit, and I'm an advocate for many marginalized groups. I need to ask the entire room to refrain from using labels today, because when you use a label like inmate, convict, give me some more, you are making me have a visceral response. You're harming me. And I can tell, I know there's other people in this room who are harmed. So person first language, and if you don't get why giving a person his dignity, then you can say, why would you want to call somebody what you don't want them to be? Thank you. And so here's my question. Being a 12-stepper, I'm now living a sober life for 12 years. I know, Senator Austin, you spoke about a lot of mental health issues, but you seem to separate a bit on substance abuse. And I know as being in the 12-step rooms that a lot of our individuals have co-occurring diagnoses. They're bipolar, they're triple occurring diagnoses. So I also know by working with the group I work with that people are accused of crimes and they don't know if they did it or didn't do it because they were in a blackout. Or once you put the drink down, you have a lot of work to do because of, what are the systemic causes of your drinking. So I would like to see alcoholism has made it into the DSM just like diabetes. So will you be treating it in your mental health committees the same or different? Thank you.
So thank you for that. And I believe what I said was my concern is that people that were in our psychiatric institutions, which were chronic schizophrenics, those with bipolar, those with deep depression, are being lumped in with substance use disorder, which is a different mechanism. And I believe both should be treated, but there should be a clear distinction. There are some that co-occur, but there is a distinct not looking at what real mental health is about those people that have genetic conditions that are leading to their mental health conditions. Now, this last year, working in the legislature, we put money in for alcoholism for work within the confines of the Department of Corrections. Personally, I always thought that alcohol was the worst detox. They're the one detox that when it happens within the confines of a correctional facility that requires that person to be put in the medical unit, because it is the one detox that we have of all of the substance abuses that can lead to death. And so I think alcohol is a very serious issue, and I think it's not looked at. Many people get involved in the issue of fentanyl and thinking that that's the worst problem we have. I always have thought alcohol is the worst problem we have. I have many family members who are alcoholics, and some are alcoholics still using. It's a very difficult situation, and it's not something that I would ever ignore.
Okay, thanks. I believe we're out of time, unfortunately. I want to thank these panel members, first of all, for your shared experiences, for your shared insights, for your amazing work, and for prompting a lot of discussion here today on this pivotal issue. Thank you.